we're going to discuss an active case study that has to do with time management and professional nursing, presented by Wendy McIntyre. So to begin with, we're going to review the available staff that we can assign to the clients that we will look at next. And we're going to start out looking at the charge nurse, which for this scenario will be designated as myself, which is a BSN RN with 10 years of medical surgical nursing experience and it's been on the unit for 6 years and 3 of those years as the charge nurse. Then you have Pat, who is a new graduate RN with less than 1 year of experience in nursing, and this is their first job as a nurse, and they just completed orientation last week. So this is their first shift with our current team, and they're by themselves. Then we have Logan, who is an LPN that has been nursing over 20 years, 10 of which has been in medical surgical nursing and on this floor. And then we have Alex, a nurse who is BSN RN that has been nursing over 15 years, the first 12 which was in labor and delivery, and the last 3 have been on this floor in medical surgical nursing. Then we're going to go look at the nursing assistants that we have that we can assign to patients. And we start with Shelby, who is an NA1 and has been working their whole career of 6 years on this floor. Then we have Francis, who's an NA2 that's been working for 3 years and only 1 year of that has been on this floor. And then we have Charlie, who's an NA1 that just graduated and started working on this floor 6 months ago and completed orientation 3 weeks ago. Next, we're going to look at the client list and get a general overview of what their diagnoses are and what their current orders are. And as we go through the presentation, if you feel you need to review conditions of the patients, you can rewind and look at what their current orders are, medications, and conditions to remind yourself as we continue through. So our first patient is Amelia, who's a 65-year-old female. She's in with severe anemia due to GI bleed and a non-healing wound on her left foot that looks to be turning gangrenous. And she also has other comorbidities such as diabetes, obesity, hypertension, and depression. She's alert and oriented person, but her hands and lips are slightly cyanotic, and she is very pale. Her current orders include type and screen, and then transfuse 2 units of packed red blood cells, administer oxygen as needed to keep saturations above 93%. She has a CBC draw 2 hours after the blood transfusion is complete. She has dressing changes to the left foot twice a day. She has a finger stick blood sugar monitoring before meals and at bedtime, and uses a sliding scale with insulin being administered when her blood sugar is greater than 150. She also has pre-medications of acetaminophen and diphenhydramine, 1 dose before her transfusion, and then she also has an order for chest X-ray, posterior, anterior, and lateral to rule out pneumonia. Then we have Jethro, who's a 58-year-old Caucasian male with severe pneumonia. He's recovering and just came down from ICU last night. His other diagnoses include hyperlipidemia, alcohol abuse, nicotine abuse, cocaine abuse, and hypertension. He is on a ventilator on Symvene setting with 12 breaths per minute. His respirations are extremely labored and uneven. He appears cyanotic, pale, and extremely anxious despite medication, and he cannot talk due to being ventilated. But his nonverbal pain scale shows that his pain is 10 of 10 for the last 2 hours despite receiving medication. His current orders include weaning from the ventilator as able, morphine 2 milligrams IV as needed for pain greater than 5 to 10 every 6 hours, normal saline at 50 milliliters per hour, Ativan 1 milligram as needed every 4 hours for anxiety, and a chest x-ray to reevaluate the pneumonia, and suction with inline suctioning every 2 hours as needed. Our next patient is Jason, who's a 23-year-old African-American male. He's on suicide watch due to attempted suicide with pills. Other diagnoses include depression, anxiety, bipolar, and post-traumatic stress disorder. He's alert and oriented, ×4, and very cooperative. His oxygen is 99% on room air, and he has telemetry. His current orders include one-on-one watch with suicide precautions, transfer to psychiatric hospital after a psychiatric evaluation consult is complete. So then we have Gertrude, a 78-year-old female, in for syncope due to orthostatic hypotension and pacemaker malfunction. Other diagnosis includes third-degree heart block with pacemaker placement 3 years ago and heart failure. Acute myocardial infarction ×3, had a CABG, which is coronary artery bypass grafting, ×2 vessels, hypertension, hyperlipidemia, and early Alzheimer's dementia. She's nauseous, has vomited once in the last 5 minutes, and complains of dizziness. She's alert but totally confused, but normally her baseline is she's confused to time only. Her current orders include schedule for pacemaker replacement in the AM, nothing by mouth after midnight for procedure, administer oxygen as needed to keep saturations above 93%, monitor telemetry closely for changes from baseline, and report changes as needed for treatment orders, and out of bed to bedside commode with assistance only. Our next client is Jenny, who is a 55-year-old female admitted directly from the emergency department, awaiting surgery to repair a comminuted fracture to the left femur that occurred as a result of a physical altercation with her wife. Other diagnoses include hypertension, depression, and anxiety. She has telemetry running with sinus tachycardia. She has a cast applied to her left leg to keep it stable until surgery, which is scheduled for the AM. She is alert and oriented, ×4. She's diaphoretic and complaining of 10 of 10 pain to her injured leg. Her toes on that leg are bluish and cold, and she can't seem to obtain relief from pain despite 2 doses of hydromorphine PRN per the orders given over the last 5 hours. Her current orders include 1 milligram of hydromorphone IV for pain greater than 6 out of 10 as needed every 2 hours, morphine IV 2 milligrams as needed for pain greater than 6 out of 10 every 2 hours for breakthrough pain, nothing by mouth after midnight for surgical repair in the morning, apply Buck's traction to left leg at 10 pounds, Labatol 50 milligram IV PRN systolic blood pressure greater than 150 and oxygen as needed to keep saturations greater than 93%. Then we have Cara, who's a 28-year-old female, in for diabetic ketoacidosis for type 1 diabetes. Her other diagnosis includes kidney insufficiency, cocaine abuse, alcohol abuse, nicotine abuse, and bipolar depression. This is her 7th admit to the unit for the same diagnosis in the last 6 months. Her current oxygen saturation on room air is 98%. Her respirations are at 14 and telemetry is running normal sinus rhythm. She's alert and oriented ×4. The night nurse reports that the client frequently pushes the call light and then pretends that she didn't because she wants someone to talk to, but she wants to have someone in there for long periods of time. She also repeatedly calls claiming that she's having chest pains, only to say she's okay once the nurse comes to check on her. When you try to give her restrictions on always hitting the call light or telling her the nurse will not come back to talk to her, she walks in the hallway naked. Her last fingerstick blood sugar an hour ago was 156, and her insulin drip did not require adjustment at that time. Her current orders are to maintain her insulin drip based on sliding scale orders, fingerstick blood sugar every 2 hours as needed for symptoms of hypoglycemia, dextrose 5% in water, IV continuous infusion at 45 milliliters per hour, discontinue insulin drip when fasting fingerstick blood sugar is less than 150 for 3 consecutive readings, and administer IV D50 1 amp as needed for fast fingerstick blood sugar less than 30, and complete bed rest until insulin drip is discontinued. Our last two clients we have Cheryl, who's a 63-year-old female, in for transit ischemic attack that's resolved in monitoring. Other diagnoses include hypertension, hyperlipidemia, obesity, nicotine abuse, AFib, and heart failure. She's alert and confused to place and time. Her baseline is normally she's alert and oriented times 4. She was also noted to be saying things that didn't make much sense this morning on last rounds, which were about 10 minutes ago. Her current orders include neural checks every 2 hours, oxygen PRN to keep SATs above 93%, and nothing by mouth until speech therapy evaluates ability to swallow. Then we have Jamie, a 33-year-old American transgender female in with pneumothorax to the right lower lobe, who had a chest tube placed to water seal suction 3 days ago. Other diagnoses include chronic obstructive pulmonary disease, nicotine abuse, depression, sickle cell disease, which she's currently in a crisis, and history of early stage prostate cancer. She's currently on 4 liters of O2 via 100% non-rebreather mask and 85% oxygen saturation. And she has SVT on telemetry. Chest tube collection chamber is on the floor and continuously bubbling. Current orders administer oxygen as needed to keep SATs between 91 and 93%, maintain chest tube to wall suction, and convert to water seal at 1700 today, 9% normal saline at 100 milliliters per hour, IV continuous fluid, encourage fluid intake by mouth, IV hydromorphone 1 milligram as needed every 4 hours for pain greater than 6 out of 10, and Ativan as needed for anxiety every 6 hours. Looking at the assignments given the nurses for the client list that we have Alex, who has 15 years of experience, so assigning her to Amelia and Jamie allows for her strong assessment skills to come into play and her good critical thinking skills, which needed for Amelia, who has many comorbidities and is showing signs of possible sepsis because she meets SIRS criteria on many different aspects as far as temperature, a current suspected infection, increased heart rate. And then with Alex, who has a pneumothorax and already has COPD, which increases the difficulty of oxygenation, and the chest tube with continuous bubbling, which is evidence of a leak somewhere in the suction system. You have increased pulse and respirations from a combination of sickle cell crisis and the pneumothorax not being properly reinflated due to improper functioning of the chest suction system. So you need to also assess for pain and to properly medicate with PRN medications. So giving those two patients to Alex allows for those patients to get good care with a nurse that's experienced with dealing with very, very critical patients. Then we go to the 2 clients that are assigned to the charge nurse, which is myself, who has 10 years of experience, 3 of those being as a charge nurse, therefore also requires critical thinking skills and assessment skills, and understanding the basic operation of a ventilator, which, being on the floor as long as the charge my nurse has been, you'd be exposed to that and understand the basic operation of a ventilator and know with the patient's current signs and symptoms that respiratory needs to be called due to inadequate oxygenation. Also, recognition of Jenny, who is showing intractable pain despite pain meds given, with her diaphoresis, cold and clammy extremity on the affected leg, which shows the possible compartment syndrome. So therefore you need to be prepared to contact the physician and let them know what the background is and what their current condition is, and that be ready for them to order possible removal of the cast and even prepare the patient for a fasciotomy procedure in order to relieve that condition, because that is an emergent condition. Then you have Logan being assigned to Jason and Cheryl, and Logan is an LPN with 20 years of experience, and so therefore they'll be able to understand the therapeutic communication needed to maintain the stability of a suicidal patient while waiting for that site consult. Also, less critical patients between Cheryl and Jason allow for the LPN to take on extra delegated tasks, possibly for the charge nurse patients, or even for Alex's patients, or even just helping the new RN Pat with her patients, with her having 20 years of experience that'll allow her to guide and or even know when to report things to the RNs as needed to properly take care of those patients. Then you have Pat, who's the new RN grad. Her patients have less severity conditions, but still needing an RN who's able to take care of their conditions. Gertrude having nausea and dizziness, hypotension, confusion, that are changes from her baseline. So therefore the RN could contact the physician to request perhaps an IV bolus of normal saline to perhaps bulk up her blood volume, seeing how with Alzheimer's patients they often forget to drink enough, so hypovolemia is an issue. Monitor for changes in the mental status and report those to physician as needed. With Kara being stable, not with her insulin drip, but being a needy patient, needing constant attention, then the new RN could set her with her at the nurse's station so that she could discuss and have conversations with her in order so that Kara wouldn't be up walking around naked and bothering other patients, and Pat could make sure that she could still monitor her blood glucose levels in case there is a change needed to her insulin drip. When assigning clients for the CNAs, we assign Amelia, Jethro, and Jenny, which are more critical patients, to the NA2 due to their expanded scope of practice. It allows for further task delegation, so their ability to suction and complete dressing changes will help lessen the workload of the RN, which will allow for increased support for everyone, and allow the nurses to concentrate on assessments that are emergent, and therefore rely more on Frances to complete tasks that she is able to within her scope. Assigning Charlie to Jason, who is on suicide watch, since Charlie is the least experienced, this will give him a chance to kind of see how the floor works while remaining a sitter for Jason, and allow utilization of more experienced staff in other areas. Now, as far as Shelby, who is a CNA1, assigning her Gertrude, Cara, Cheryl, and Jamie, she'll be able to support the new RN on the floor with orientation as far as the unit setup and where supplies are as needed. Shelby's years of experience will lend to her understanding procedures and being familiar of the patient's types seen on the unit. And in assigning less intensive tasks, patients to Shelby, it allows Frances to be assigned to the patients where her increased skill set will be better utilized. Current orders for the patients that are assigned to the charge nurse, we're going to look at just those two patients throughout the rest of the presentation. So for the patient Jethro, his current orders include weaning from ventilators able, normal saline at 50 milliliters per hour, morphine 2 milligrams IV as needed for pain greater than 5 out of 10 every 6 hours, Ativan 1 milligram IV as needed for anxiety every 4 hours, a chest x-ray today to reevaluate pneumonia, and suction with inline suctioning every 2 hours. Patient Jenny has 1 milligram of hydromorphone IV for pain greater than 6 out of 10 every 2 hours, morphine IV 2 milligrams as needed for pain greater than 6 out of 10 every 2 hours for breakthrough pain, nothing by mouth after midnight for surgical repair in the morning, apply Buck's traction to left leg at 10 pounds, labetalol 50 milligrams IV as needed for systolic blood pressure greater than 150, and oxygen administration as needed to keep saturations greater than 93%. Looking at the two assigned patients for the charge nurse and their condition after assessment and looking at what currently is going on with them, additional needed interventions and task priorities seems to be that first you need, for Jethro, first you need to assess lung sounds and assess oxygen saturation. Then you need to also be checking for vent tubing for kinks or leaks to make sure that his reduced oxygen saturation doesn't have to do with any of those problems. Then you need to communicate with respiratory to evaluate uneven labored respirations and ventilator settings and make sure that his chest x-ray gets completed so that we can evaluate how his lung condition is to see if perhaps it has worsened instead of continuing to get better. His morphine 2 milligrams IV need for pain when it's greater than 5 out of 10, which he's showing pain of 10 out of 10 with his nonverbal communication, and his Ativan as needed for anxiety every 4 hours doesn't seem to be working, which we need to speak with his physician to evaluate that with his history of abuse of alcohol and cocaine and other opiates, that order may not be enough, that may need to increase those due to his abuse history. And then we need to make sure that suctioning is being completed every 2 hours as needed to help clear those secretions to allow oxygenation to improve, and hopefully by addressing all these issues that we can improve his condition and get him off that vent. After looking at the overall condition of client Jenny, additional needed interventions needs to be contacting her physician to let him know that the morphine given for breakthrough pain is not being effective, and that we need to check for her femoral pulses on the left leg to make sure that there is circulation going to that leg. Make sure we perform neurovascular checks for pain, paresthesia, pallor, paralysis, poikilothymia, and pulselessness to make so that we can let the physician know that her pallor and temperature change in that extremity is either improving or getting worse, so that we know that we could possibly need to remove her cast or possibly perform a fasciotomy in order to relieve the pressure in that extremity so that she doesn't possibly lose that extremity. Make sure we're removing restrictive clothing, maintaining leg at heart level so that proper circulation can continue to go to that extremity, making sure that we're providing the PRN Labatol 50 milligrams since her systolic blood pressure is greater than 150, and applying the Buck's traction unless order is changed after having the S-bar with the physician, since she does show signs of compartment syndrome. Make sure she maintains her NPO after midnight so that surgical repair can still be completed in the morning, and making sure her oxygen stays greater than 93% and giving her oxygen as needed if it drops below that, which right now she is stable as far as her oxygen level. So just make sure that we are communicating with the physician what's going on with her, because compartment syndrome is emergent and we need to make sure we address that first and foremost. After prioritizing and making sure that we understand as a nurse what we need to be doing, we need also delegating tasks to others, like for Jethro's delegating his sectioning every 2 hours, since we understand that that's important to keep his oxygenation at optimal levels, and that the CNA2 can also obtain O2 level via pulse oximeter and then report those results to the charge nurse so that the charge nurse can evaluate and make a decision on what other interventions may be required based on those O2 levels. Then we have the delegated test for Jenny, removing her restrictive clothing, helping to maintain her leg at a heart level. They can obtain the blood pressure and report that to the RN so that we know how effective the PRN Labatol is, and we can evaluate if she needs more medication to help control that blood pressure, or if it's actually being effective in controlling that increased systolic blood pressure level. And then they can also help enforce the NPO after midnight so that we make sure that Jenny doesn't receive anything by else, so that she can have that repair of her leg break in the morning. Verifying that these tasks have been completed, we can assess the patient after verification from the NA that the task has been completed, and then we can verify that proper documentation has been completed to make sure that we understand that those tasks have been completed properly. When it comes to professionalism and time management, you just need to make sure that as a nurse you're communicating well with your other members of your healthcare team, asking for help when needed, performing tasks in a proper manner, making sure anything you delegate that you maintain accountability for those delegated tasks, checking back on making sure they're completed in a proper manner, making sure that you're not on the phone when you shouldn't be, that you should be working when you're being paid to work, and just overall communicating in a manner that is respectful and professional. And here are the references that I've cited that I used in order to prepare this presentation. I hope that this helped you understand time management and prioritization a little bit more. I know I learned a lot. I thank you for watching my presentation and appreciate your attention. Have a good day.